Could you discuss the optimal treatment approaches for managing HIV-positive patients who are also using methamphetamines and/or other stimulants?
Yeah, stimulant abuse is very disruptive for patients. They come in and out of care. They're less than ideally adherent to their treatment. And stimulants are very tough because when patients are using them, they become overwhelmingly connected to the stimulants. So opiate users really are only impaired for modest amounts of time each day, and they tend to use it on a regular basis. Stimulant users use in these huge waves where they really often are very intoxicated for periods of time. And then for a while they'll back off. And of course every pattern is different for every patient, but generally that's the pattern. So in terms of optimal treatment, you really want to detoxify patients with stimulant use. Occasionally you'll see someone with stimulant psychosis, amphetamine psychosis. They look very much like they have schizophrenia, and they can be quite dangerous because they're very paranoid. Otherwise, most stimulant users are just revved up and disorganized. But it increases high-risk sex. They might be very good candidates, for instance, for some intervention that is prophylactic against spreading or getting infected. Their sexual behaviors are not only higher risk, they're higher frequency. So they often come in with sexually transmitted diseases of a variety of sorts. And so you want to survey for those things when you see the patients. If you can get them into detoxification and rehabilitation treatment, that's the best. Patients often have little insight when they have stimulant abuse that it's really ruining them, but you can talk to them about it. I confront patients with a smile, but I confront them and say, no, you're using way too much and you're really in trouble here. Getting outside people a person is connected to, family, partners, really helpful and really useful for those patients. Once they're in care, detoxification and rehab are the mainstays of treatment. It's fairly much the same you would treat any patient with a substance abuse disorder. The mainstay of treatment is group therapy and interpersonal support. Behaviors like addictions change best with group. So group therapy, AA-NA combinations, specialized groups for gay men with substance abuse problems, especially with stimulant problems, are around in many places. And they do quite well if they get in and stay in. Opiate cravings last longer. Stimulant cravings are more intense. So one kind of cool experiment with the animals is a hungry animal will push a lever 50 times to get food, 500 times to get opiates, 5,000 times to get stimulants. So it's much more reinforcing. It drives behavior more intensely. On the other hand, once you stop the stimulants, the animal will stop pushing the lever first for stimulants. If you shut the machine off so that no matter how many times they push the lever, they don't get any reward, they'll stop fairly quickly. They'll return to that behavior in pulses, but they'll stop fairly quickly. So if you can get people away from the drugs long enough to kind of regain their senses, often they'll do pretty well in rehab. They're high risk for relapse down the road, but they'll do pretty well. So the mainstay, again, is treatment. And again, integrated care is the key. If you can get someone who's an expert in your clinic so that the care is connected to the HIV care, patients do much better.